And it is my pleasure to introduce you to Dr. Alba Posligua. And Dr. Posligua obtained her MD degree from the Catholic University of Guayaquil, Ecuador, and completed her first dermatology residency in Centro Pascua at Mexico City. This was followed by research fellowships at the Departments of Dermatology at Northwestern University and SUNY Buffalo. She successfully finished her second dermatology residency at the University of New Mexico, where she currently is, and joined them as a volunteer faculty member. And Dr. Posligua will start her micrographic surgery and dermatologic oncology fellowship at the Ohio State University in July. Please correct me if I'm mistaken on that, but I want to welcome you and thank you so much for joining us today.
Thank you, Dr. Allen. It's my absolute privilege to be here. I feel very fortunate to have been invited to give you this talk. Let me advance this. I'm Dr. Posligua, volunteer faculty at the University of New Mexico Department of Dermatology. And today we're going to discuss about dermatoses in Native Americans and Hispanics, cultural responsive approach to common skin conditions in New Mexico. I do not have any disclosures, and these are the professional practice gaps that we are going to be taking care of today. And these are the learning objectives, which we're going to discuss each one of this as we follow through this presentation. Briefly, as some introduction and some terms, Natives are the original peoples of North, South, and Central America who maintain tribal affiliation or community attachment. More than 1% of the population in the US identifies as an American Indian or Alaskan Native, and intermixed with other populations, it comprises about 2.9% of the population. There's more than 500 tribes, 324 federally recognized American Indian reservations, but it's important to note that most of these people, 87%, live outside these areas. And only 60% live in metropolitan areas. And this is important because more rural communities have less access to healthcare. These are the 5 states which have more Native Americans, including Oklahoma and New Mexico. 2 fundamental principles define this unique population: tribal sovereignty and the federal trust relationship between the US and tribal government. The IHS is a division within the US Department of Health, which takes care of education as well as health access. But an individual must be member of a federally recognized tribe to experience this benefits. This is important because we already discussed that some groups are not federally recognized, as well as access in rural areas. Native Americans is not a homogeneous culture. They do share a past and current cultural identity, but its most important shared element is the historical trauma and loss that they have suffered, including relocation and criminalization of ancestral practices, including traditional medicine. What about Hispanics in the US? Nowadays, it's 18% of the US population, but by 2050, it's going to be a quarter of the US population. Historically, they have experienced anti-immigrant prejudice and racial and ethnic prejudice, which have impacted the employment and housing and education reach that they can have. But we want to define certain things. This has already been discussed in some of the prior talks. Race is a social construct that emerged in the colonial period. I wanted to show this painting on the right because this shows a Spaniard father and then a Native Mexican mother, which results in the child that it's a mestizo, that means a mixed race. In the colonial period, Spain, as well as other countries, they created this caste system, and this was a construct to tell the individuals, according to their race, what they could achieve in life. Ethnicity, it's a person's cultural identity, which include language, customs, religion, etc. And then I also wanted to discuss these terms about what is Hispanic and Latino. Hispanic, it's a term that emerged in the 1970s, this term basically comprehends people from Hispania, meaning the historical Iberic Peninsula, Spain, Portugal, but it also comprised other Spanish-speaking countries that were colonized, mostly Latin America. But what about individuals that are from Equatorial Guinea, that it's in Africa? They also speak Spanish. Are they Hispanic? Or what about Philippines? They also have a lot of Hispanic background, many last names that are in Spanish. Are they Hispanic as well? Or what about the opportunities that a white man from Spain has compared to a brown man from Mexico? Are they the same? And what about Portuguese and Brazilians? Do they consider themselves Hispanic, and what do they answer in a census? So those are questions, because this is not a perfect term. And later, it was developed this Latino, Latina, Latinx, Latin term, which basically is descendants from Latin American populations and countries. But it's also not perfect, because some people may not identify as itself. In the census in 2020, it was found that most of the Hispanic individuals in the US are from Mexican heritage, more than 60%, followed by Puerto Ricans, Central Americans, South Americans, and other Hispanic populations. And these are the 10 states where have most of these populations. We're gonna start with our first objective: review the diagnosis and treatment of as common skin findings in a range of skin types, including Native Americans and Hispanics. We're going to start first with atopic dermatitis, which is a very common dermatosis that we observe in up to 20% of the pediatric population. As we have noticed throughout this symposium, erythema or redness may be harder to appreciate in patients with a skin of color. And in 2019, this paper was from Dr. Jonathan Silverberg described that Hispanics tend to have more trunk involvement, and as well as papular and perifollicular presentation. Many patients have behavioral changes as well as depression, and if they have severe atopic dermatitis, they tend to give up on themselves. And then another thing that I wanted to add is that in this paper from 2021 that was in native populations in Canada, they found that impetiginization or overinfection, it's more common in this group. And we found it as erosions, crusting. Usually if we swab this, it's gonna be a methicillin sensitive Staph aureus. And then we as providers, we're gonna tell them to start doing dilute bleach bath. And of course we swab them and we found an infection, we're gonna have a low threshold for oral antibiotics. But then we have to ask ourselves something very important, especially in our communities that are very rural. Do they have access to running water or to clean water? Do they have access to a bathtub? Are they going to be able to do this dilute bleach bath? And then another thing is that these communities, some of them are really isolated. So do they have access to over-the-counter products or even a budget for it? And then in the Southwest, we have suffered of many fires in the last few years. So wood smoke, it's something that has been found that may be a trigger, as well as hay and dust. Another interesting paper found that in Native American communities, this is from Canada, they found that Contact dermatitis may be a trigger as well, or maybe a differential diagnosis too. And these are some of the common culprits, the ones that you find here on the screen. But also we have to consider something else. Maybe the severe extensive eczema, it's an heat reaction from a contact dermatitis or from a tinea pedis. So maybe we misdiagnose this. So it's something that we need to think about as well. So the next condition that we're going to discuss is psoriasis. This can present at any age. It's a common dermatosis. We already know that it can or cannot be itchy. And it presents as this pink scaly plaques with crisp, well-defined edges. And it affects the scalp, the folds, as well as elbows, knees, and the buttocks. In Hispanics and other skin of color communities, such as African Americans, it tends to be more severe. It's less prevalent, but more severe. And in Hispanics group, it has been found that there's more pustular presentations, so something to take in account. Again, redness is going to be difficult to appreciate in a skin of color individual, so something to consider as well. And then it can be associated to other conditions such as psoriatic arthritis, cardiovascular disease, obesity, because it's a multisystemic inflammatory condition. And these patients may have a behavioral health impact that may be very important, as well as we should evaluate about substance use disorders. Briefly, we're going to discuss about some drug eruptions. First, we have this morbilliform rash that presents as measles-like maculopapular. You can see the reticular kind of appearance. I wanted to show you the picture on the upper right, where this reticular appearance is very faint and kind of difficult to observe. And this is what happens with redness in a skin of color. So we need to be more cautious about that. This condition can or cannot be itchy. It can be induced by drug or viral triggers, and either one of them is indistinguishable. And basically, we do asymptomatic management. Urticarial presentation is the presence of transient wheals. There's going to be this edema. It can or cannot be itchy again. It can be triggered by drug, food, or a virus. In the acute phase, is less likely to be idiopathic, but if it's a chronic, more than 6 weeks kind of urticaria, we tend to think that it could be idiopathic. But we also have to think about other autoimmune processes, such as thyroid disease. If there is any drug that it's the offending cause about this, we stop it, because there's always a risk of anaphylaxis if we continue re-challenging our patients with this medication. And in both conditions, treatment can be done with antihistamine, topical corticosteroids, and other medications as needed. I also wanted to show you the picture on the right lower left, right lower screen, where we again see a patient with a skin of color. The wheals are very subtle, almost papular, but there is redness there. And more serious drug eruptions, such as AKA DRESS syndrome, that is the drug rash with eosinophilia and systemic symptoms. Of course, patients are going to be more sick. They're going to present with fever, malaise. They may have lymphadenopathy. Every system in the body can be affected, from the skin, liver, lungs, kidneys. And the eruption tends to be non-specific. What it's more commonly seen is facial and acral edema, as you can see on the picture on the left. This puffiness around the eyes is very characteristic of this eruption. And this is weeks after starting the offending medication that we observed this eruption. Eosinophilia, even though it was part of the DRESS name, it's not always present. Some authors say that between 40 and 60% do present eosinophilia. That means that about half do not have this this presentation. It can or cannot be itchy, and mucosa is rarely affected, but we have seen in our practice that sometimes it is. Common triggers: aromatic antiepileptics, sulfa medications, minocycline, which we use a lot for acne patients, is something that can trigger this condition. Briefly, we're going to discuss about non-melanoma skin cancer. Of course, it has lower incidence in patients with a skin of color, but due to a later diagnosis and because tumors tend to be larger and more morbid, there's more morbidity and more mortality. Hispanics tend to have a presentation of more basal cell skin cancer, which is the most common skin cancer. But in this group, and we see it a lot of in our practice, there's a lot of pigmented basal cell, as you can see on the screen on the picture on the left. Even though it's ulcerated, we can still see the globules of pigment here, even without dermoscopy. And then Native Americans at UNM, there was this a retrospective review that was done a few years ago. And in 26 patients, 28 tumors, it was found that in Native Americans, 16 were basals, followed by squamous. None of these patients were immunosuppressed, and 4 of these patients did have history of skin cancer, past medical history of skin cancer. It's important to note that in different areas, and I'm going to talk about New Mexico a lot, we do have altitude as a factor here. We have clear skies more than 310 days of the year. There is still active mining or historic mining here in the state with exposure to arsenic and other heavy metals. And we do have sites where there were nuclear tests for the nuclear bomb in the 1940s. So that's another factor that may influence the presence of non-melanoma skin cancer in our population. What about melanoma? In this study that was done in California, more than 40,000 adults with melanoma, only 27 were identified as native, with 1 death among this group, which tell us that there's an inadequate collection of Native American populations. And they also found in this study that Hispanics with lower socioeconomical status had a more mortality of melanoma than other groups. That delay in care explain why many individuals that are of skin color present later in the stage of melanomas, but there's also disparity in access to treatment. It has been observed in some studies that being of a skin of color, patients receive less immunotherapy than white, not Hispanic. At UNM, we have a confocal microscopy. I just wanted to share this data. And in a prospective study with 22 adults with melanoma in situ, 20 were able to be clear with a 3mm margin. Therefore, I just wanted to share this, that maybe it's a tool that can help us to get smaller margins and less morbidity for our patients. I wanted to share this slide that it comes from the University of Oklahoma, where it was shown that there is more prevalence, only followed by first are the white non-Hispanic, but the second group that are more prevalent are the Native Americans, as well as mortality from melanoma. This is the second group after white non-Hispanics. Briefly on mycosis fungoides, which is a T-cell lymphoma. The incidence in white individuals is 6.1 per million, and in patients with the skin of color, particularly African Americans, is 9. It has been observed that MF has a worse prognosis in skin of color patients with larger mortality. And in a skin of color individuals, it can present as hyperpigmented erythematose, meaning red, or hypopigmented variant, which is almost exclusively seen in skin of color individuals. On the left, we have this picture where we observe this hypopigmented patches. It's observed mostly in some protected areas, such as the buttocks, the thighs, and the inner arms. Briefly on photoprotection, because this is going to be discussed later, here in New Mexico at UNM, there was a questionnaire of more than 400 participants, and it was observed that Native Americans had less sun protective measure and less skin checks compared to peer. In the University of Arizona, they did a similar questionnaire, and they found it was a little bit different, because they found that More than 80% of the Native American individuals reported at least one sunburn, and more than 30% had regular use of sunscreen, at least on the face. And they also had 7.5% of these individuals had skin checks. In a larger data set, as we observe in the bottom, they found that Native Americans have less sun protective measures, more sunburns after 1 hour, more tendency of having indoor tanning, only second to white non-Hispanic, and higher rates of melanoma diagnosis. They lack access to skin checks as similar than other skin of color individuals. And I wanted to show you this slide because in this study, they show that a specific behavior promoted in images was, they show more images like in ads and TV ads and everything for lighter skin types. So we can observe here from sunscreen to tanning avoidance is shown more in individuals of lighter skin compared to Fitzpatrick 3, 4, 5, and 6. So there's a big gap there. So few perils from this portion. Hypo and hyperpigmentation may have an impact in quality of our patients. So if we have a patient with eczema or psoriasis, it's very important to start a discussion that even though psoriasis or eczema are improving, there's going to be some residual hyperpigmentation. And having this conversation early may decrease anxiety of our patients because they will know that this will improve with time. Skin cancer in general has lower incidence in skin of color individuals, but tend to be diagnosed later and undertreated. That this is something that we need to address. And in this community, sun protection and skin checks are not as consistent and common, and advertising is not even like targeted to them as much. So we need to do a better job on this. Secondly, we're going to go to the next objective, identify the conditions more prevalent in these populations. Briefly on hidradenitis suppurativa, this is a common chronic inflammatory condition that presents on the folds, and etiology is related to follicular rupture and friction. It's more commonly observed in female individuals between the 3rd and 4th decade. But when we ask our patients that we do in our clinic, when do you start observing these boils for the first time? Some of them will tell you that in their puberty, some of them will tell you as early as childhood. So this is something important to note. The prevalence in the literature goes from 0.05 to 4%, but it affects mostly skin of color patients. Black, Hispanic are much affected, and the prevalence in Hispanics, it's high, and the severity as well. In a retrospective cohort from Stanford, that this is quite recent in 2021, they found that in this large cohort that only 3 Native Americans were identified, which, you know, in our practice, we observe a lot of Native Americans and Hispanics. And also in this study, they found that this condition has a heavy economic impact due to the extensive severe disease that they are when they are diagnosed and when they start treatment. So this is very important as these patients stop working because they have flares of these conditions, and this impact their economic ability readily. As clinical criteria, we have this 3 criteria on the screen. Patients have nodule, abscesses, tunnels, scars. There's more than 2 lesions in 6 months, affects mostly intertiginous areas, such as axilla, abdomen, pannus, groin. And it can go together with other follicular conditions such as dissecting cellulitis of the scalp, acne conglobata, pilonidal cyst. These patients also tend to present other comorbidities such as metabolic syndrome, meaning obesity, diabetes, hypertension. There's also more polycystic ovary disease, and there's more incidence of cigarette smoking. This is something that we ask our patients to stop. It's not a cause, but it can exacerbate the condition. There's also more prevalence of Crohn's disease and spondyloarthritis. These patients also have a great impact in their quality of life, a lot of mental health issues with them, depression, risk of suicide. So this is something that we need to evaluate promptly. And treatments, we're not going to discuss about all the treatments available. There's topical, systemic, including biologics. And we also advise our patients changes in lifestyles. Importantly, clinical trials are trying to increase the diversity, but we still have a lack of minority in most of the clinical trials. And in the next slide, I wanted to show you this. As American Indians, we already discussed that they represent between 1 to 3% of the population at large. And in studies at most, they have been represented at 0.14%, which is super low. The Hispanics is the same. They represent 18% of the population. And the most that they have been represented is about 10%. So there's more that we need to do. It's very important to know that why they're not in rural studies. There's many reasons for that. There's disparities in socioeconomic status. There's limited centers where these populations live that are running clinical trials. And then there's also a lack of trust in the healthcare. These populations, skin of color in general, have lack of trust in the healthcare system, particularly because of historic reasons. And as well as to difficulties in having time or financial access to go to the sites of the clinical trials. They have to drive there, and they have to lose time of working. So it's difficult for them to assist to clinical trials. Acne vulgaris, in our practice, we see some of the most severe cases in Hispanics and Native Americans. In this study that I'm showing you here, 158 adults from Native Americans answered questionnaire, and 79% answered that they have past medical history of acne. 34% already experiencing scarring, and 31% still have active acne lesions when they answered this questionnaire. Of all these people, only one was seen by a dermatologist. It's important to note that, as in other conditions that we have already discussed, post-inflammatory pigmentary changes are very prevalent in these groups. And also they may have post-acne keloid formation. So important to treat these patients promptly, important to treat them sometimes aggressively if we know that there's a risk for keloids. But the data says otherwise. What we have been doing is treating them less aggressively. There's less use of oral medications in these groups, including isotretinoin. And this is a problem because these patients have more risk of scarring and pigmentary changes. Next, we're going to discuss about actinic prurigo. This is a photodermatosis that may be familial, meaning that in several generations it can present. Appears in childhood, a median age is of 8 years old. It's mostly seen in female young girls, Native Americans, or mixed race. We already discussed what is the definition of mestizo, and it presents throughout the American continent. There's this HLA-DR4 antigen that has been identified in 90% of the cases. This was a study done in Mexico. And in a different study, they found that 3.9% of the derm visits in Mexico are related to actinic prurigo. So it's a condition that it's well known, and there's a lot of experience treating this condition there. These papules are very itchy, form plaques, and they tend to appear in sun-exposed skin. I wanted to show you this picture here because the lower lips, it's almost always affected. I have never seen an actinic prurigo without the lower lip being affected. In a study that was done in conjunction with Wake Forest as well as Mexico, they found that in 75 cases, the 75 had lip affection. So something to take into account. It can also affect the conjunctiva, the ears, and it can extend to a photo-covered skin, so a skin that has not received any sunlight. One of the important things is that it's observed in populations that are like in more than 1,000 to 1,500 meters above the level of the sea. I put here on feet as well. And it has also been observed in populations that have exposure to wood smoke and farm animals. Most of these cases will improve in late adolescent, but it can prevent, like it can stay as well as an adult, or it can have an adult onset. There's Inuit populations in Alaska that present with more conjunctival involvement, and these patients have worse prognosis as it is more chronic and it's more difficult to treat. We do perform biopsies, but it's not for ruling in, it's to rule out other conditions such as lupus. We also do some blood work as well to rule out other autoimmune conditions. Treatment, very important, photoprotection, it's very important in this group. We can start topical, sometimes systemic corticosteroids. Other treatments that have been used with a variable success is cyclosporin, as well as pentoxifylline. But the medication that has been more helpful, it's thalidomide. Of course, it has its caveats, and we need to counsel our patients about potential malformations if the patient is a female in childbearing age. And there's a couple of recent case reports of successful use of dupilumab to treat this condition. Next, we're going to discuss about pemphigus. It's an autoimmune bullous disease that affects the suprabasal area of the epidermis, and it presents with large bulla in mucosa and skin, erosions in mucosa and skin, and it affects adults of both sexes between 40 and 60 years old. There's an interesting study that was actually done many years ago here at UNM, and they found that the prevalence in Hispanic New Mexicans was about 4 times more common than in non-Hispanic whites. And they found that this prevalence was similar than Ashkenazi Jews from the data of that time. So they hypothesized that there was a large population of crypto Jews from Sephardic origin in these areas. If we remember the story, the history, the Sephardic Jews were expelled from the Iberic Peninsula, from Spain and Portugal in the 15th and 16th century, and they were followed by the Inquisition. They were forced to convert. So some of this Sephardic Jews, they hid that they were Jewish, and they flew to a large area that comprised today's Mexico northern area of the country and the southwestern US states, including New Mexico. So in this study, they included 70 patients where biopsy-proven, immunofluorescence-proven PV patients. And then they interview some of these patients, and they ask about genealogy, religious practices, circumcision, and they also did HLA typing in some of them. What they found was interesting. 2 of these patients confirmed that they were Sephardic Jews. With asking all these questions, they found 4 that were suggestive of this background, and then the rest of the participants either refused or were not interviewed. So it's something to take account in these isolated groups in the Southwest. Another condition is keratosis lichenoidea chronica. It's a very rare condition observed mostly in adults, but in our practice, we have had multiple pediatric patients, affects both sexes from European descent. In New Mexico, we hypothesize that they might be a founder effect because there's a large group of Hispanic population mostly that was isolated for hundreds of years in the northern part of New Mexico. So they might be a founder effect in this group. And it's related to the gain of function mutation of the NLRP1 gene, which in downstream produce an increase in caspase-1, interleukin-1 beta, interleukin-18. And in newer reports, interleukin-5 and 17 may be as well affected. All this is important because it can be used potentially for treatments. And then the diagnosis could be delayed. It's said that in a mean of about 9 years, due to its rarity, people suspect first of psoriasis or lichen planus because those are more common conditions. But this condition presents as lichenoid, pink violaceous, scaly papules and plaques in reticular patterns, mostly affecting seborrheic areas in the face, as well as mid-chest, as well as acral skin. It's very, very difficult to treat. People do not respond well to treatments. It has been tried light therapy, oral retinoids, anti-TNF. More recently, there's reports of use of IL-12/23 and anti-IL-17 with variable results. We don't have great results for these patients yet. Other conditions we have very commonly, we see in everyone's practice, is acanthosis nigricans, which is a condition that's associated with high levels of insulin, metabolic syndrome. And in this study that they did in the Midwest, they found that in Native Americans, children in a reservation in the plains, up to 19% of the children presented this. So this is important because this tells us a story about the potential metabolic syndrome, including diabetes, high blood pressure, obesity, that these patients may suffer later. And then interestingly, Xeroderma pigmentosum, that it's a rare genodermatosis where extreme photosensitivity and early development of skin cancers, which is typically the incidence in regular population is 1 in 1 million. In the Navajo Nation, it's 1 in 30,000. And again, it's thought that it's due to the low level of heterogeneous genes in that pool of individuals and a lot of endogamy. So it's that's why it's hypothesized that there is a higher incidence of Xeroderma pigmentosum. Here we observe on the screen this child with a lot of freckles, a lot of photo damage, and then some of those larger, darker spots that we observe there are basal cells, so a skin cancer. Some few pearls of this section, HS and acne may present more severely in Hispanics and Native Americans. It tends to be undertreated or not diagnosed readily, with more scarring. Some of the things that we have found in our population, and we'll discuss a little bit later, is that patients they have more difficulty to see us. They come for the most severe thing that they think is affecting them. For example, someone with alopecia areata, they will come for that. But when we're seeing them in the clinic, they also have the severe acne. So it's something that we as providers need to ask more if they want to receive treatment as well for other conditions, as it is difficult for them to come back to our clinic. And then another important thing is that research or clinical trials need to include more minorities, because nowadays it's still lacking on minorities. Actinic prurigo, it's more common in Native Americans and mixed race individuals. Always remember to check the lips, almost always is affected. And in the Southwest, we have larger pockets of crypto-Jews that may present with PV, so something to consider. And KLC may not be as rare in New Mexico. Consider this kind of rare diseases in secluded populations. The next objective that we are going to discuss is about some of the cultural practices and belief of these groups. The Native Americans in New Mexico comprise 10% of the state population. There are 23 Indian tribes, and the largest of those tribes is the Navajo or Diné group. And this is the largest U.S. Indian tribe. And in New Mexico, more than 100,000 of these individuals live. The second most populated group is the Mescalero Apache, and the third most populated group is the Laguna Pueblo. Traditional medicine is really important for Native Americans. Healers are spiritual and cultural guides, and their knowledge is passed from one generation to the next. So they are really important members of their communities. Some of the activity of the healing that they do is through prayers, singing, storytelling, and using herbal medicines. And some of the patients from Native American communities, especially older individuals, might fear their Western doctor's judgment. And then they trust more their traditional healers. So we need to respect that, as well, to listen, learn, acknowledge, and even create partnerships where their traditional healers, as well as their primary care physicians, as they tend to have more trust in someone that is seen there more often. Hair is extremely important in this group of individuals. It's part of their identity. It's a connection with their tribe, creation, and family. It promotes self-respect. And in many tribes, having a long hair represents a strong cultural identity. They take a great care of their hair, especially in ceremonies, by styling it and using ornamentation. I found this article online, and one Navajo woman said, "For Navajo people, hair it's our memory." So important to be respectful about that. Before a traditional Navajo wedding, the hair is washed with yucca root and then brushed with this bundle of stiff grass called beso. And one relative do that to the other because it's an expression of love for them. We have seen in our practice many times hair loss in this group of individuals has a great impact in their quality of life due to the spiritual attachment that they have to their long hair. What about Hispanics in New Mexico? They represent about 50% of the state population. Some of this ancestor came to the region before any other ethnic group arrived to this area. They arrived in 1598 with Don Juan Oñate, and they arrived with 500 settlers. In 1821, they became part of this new nation called Mexico. In 1836, they became part of the Republic of Texas, and later the U.S. won the Mexican-American War. In 1912, it became a U.S. state, but by then, many of the Hispanics were economically disadvantaged because many of their lands and possessions were taken away from them, and they became second-class individuals in the state. 83% of the New Mexico Hispanic population were native born, and only 17%, including myself, were foreign born. New Mexico has a special type of Spanish. Remember that this group was secluded and isolated for many centuries. So they have an old Spanish. I always compare it to something similar like Quebecois in Canada, where they have this old French. Here in New Mexico, there's this old Spanish, where different words in Spanish are not of like common use nowadays. More than 10% of the households in the US for Hispanics is multi-generational, which means that in treatments, whenever we're treating children or different individuals at home, sometimes many individuals are involved in the treatment of this patient. I wanted to describe two phenomena in the Hispanic culture, something called Marianismo, which means that women want to appear like the Virgin Mary. They're submissive, selfless, home-oriented, and they're typically responsible for maintaining the health and well-being of families. And machismo is this strong, exaggerated masculine pride. And we have sometimes issues with these patients because they tend to be reluctant to see physicians for their health problems, therefore arrive with later and more advanced conditions. In general, there is a mistrust to healthcare system, especially in first generation of Hispanics in the US. And another thing is that practices involve not only native, but also African practices, depending on the country where people immigrated from. And these cultures involve as well as spiritual, religion, prayer, and herbal medicines. A lot of the first generations rely on traditional medicine, and they have their shaman or curandero or huesero or santero. Huesero heals the bones. That's what huesero means. And then santero, it's more an African descendant in the Caribbean, Dominican Republic, and so where they also have these prayers and they also have these African practices. Some pearls, New Mexico, it's a minority state, as well as we need to be respectful with traditions for Native Americans, including their care of their hair. And also to acknowledge that Hispanics are not a homogeneous group, that most of the New Mexican Hispanics did not cross the border crossed them, and that they were before many of the other immigrants that arrived to this area. Another thing that I wanted to point out is that we need to be knowledgeable about what kind of Hispanics are in our area, because it's not the same if we are like, let's say, the New York area, where there's a more intermix of people from the Caribbean, from Mexico, from South America, as different than here in the Southwest, where you already know that most of the people come already have been here for centuries. And if they're recent immigrants, they're from the Mexico area. There's like variations in languages, in slang, as well as in some beliefs. Lastly, we're going to examine healthcare challenges and opportunities in treating these patients and discuss about the experience at UNM. In New Mexico, we have about 2 million individuals. Half of those people live in Albuquerque, where I practice currently, and the state has about 35 board-certified dermatologists. The state needs about 90. Most of these individuals are not full-time. Some of them are retiring, and it's difficult to get access as a patient if you have Medicaid, Medicare, IHS, or if you're a new patient. There's long wait times. During the pandemic, this got worse. Our wait times were about a year. And this obviously is going to impact the quality of life. There's going to create more healthcare disparities, and conditions are going to get worse as they wait for their appointment. Then UNM Dermatology as a program, we are very small. We have 9 faculty and 9 residents, but we are very dedicated to our populations and we are growing. We are based in Albuquerque, New Mexico, which is the largest city in the state. In the UNM hospital system has been traditionally very attached of caring Native American groups. And we, in the last couple of years, a clinic in Gallup, which is in the Navajo Nation on the western portion of the state, was created. It happens twice a month, and it takes care of that group. And another thing is that we recently have another clinic in the Sandoval area, which has 7 pueblos within. This is like a 40-minute drive from Albuquerque. And we are currently recruiting. So if you have any derm friend that it's interesting, UNM is hiring. We do have a strong partnership with the primary care physicians. And the reason is that we want them to be confident about managing basic non-severe skin conditions at all ages. We want them to know when to advocate for them to be referred more urgently. And we also want recognition for derm specialty, as we have very limited resources. So we need this partnership to be strong in order for them to take care of the most basic things. What about dermatology and IHS? So the mean driving from a rural IHS facility to the nearest derm clinic is 68 miles. The majority, meaning 62%, do not have a dermatology clinic within 35 miles. 32% have to drive more than 90 miles to get to a dermatology facility. And the problem is that 22% didn't accept Medicaid or IHS, so they have to drive even further. So this study that was done with the Harvard group noted that this burden it's very heavy on the patients and their families. They have to drive far away. They have to stop working that day. It also means that rural roads are not always on the best shape. They have to use their own vehicle and pay for their own gas. And public transportation in these areas is very limited or unavailable. So one of the questions is like, is telehealth something that can be used here? And our answer is maybe. Because like, especially here at UNM, if the patient is already a known patient, stable, someone that has been in treatment, and we know them that there's compliance, we can do the follow-ups through telehealth, and we do. There's very rarely derm services at IHS. Some of them do have them, but it's rare. And here in New Mexico, we have this PALS line that it's basically a partnership with outside facilities. Providers can call us and consult us, and they send us pictures, and it's determined whether that needs an urgent referral, or this is something that we can see more in a regular clinic. There's in general barriers to access specialty care in these communities. And another important thing is that we still have a lot to learn to be culturally competent and responsive in these communities. We already discussed about the sacrosanct status of care in the Native communities. We also have to acknowledge and as well as create partnerships with traditional medicine and healers of the communities, because they can have a great impact in the health of our patients. And we also have to acknowledge that there is distrust in Western medicine, particularly Native Americans. Very important to always ask them about being respectful about their hair, being respectful about testing, including biopsies, because that may generate more distrust in them. As I was just telling you, sometimes the patient comes for another complaint, but they're already here, and we see that there's like a severe acne. We should probably treat that as well. Some of our initiatives include this ECHO program. There's free registration. There is like a short basic lecture by the faculty here at UNM. There's presentations of cases that are sent by the participants. And this is something that is done every Friday at noon in Mountain Standard Time, led by Dr. Durkin. We also have this primary care derm meeting that we do on the summers. It's a hybrid model. It happens here in Albuquerque, but it's also through Zoom. And it's our core faculty participates on this. I participated last year, giving a skin of color talk there. And there's also procedural workshop as we teach our primary care physicians to do a shape biopsy or to do a punch biopsy. Teach them how to take pictures so they can, whenever there's a referral. This is going to take place on June 3rd of this year, and here is the link if you're interested. And then we also have an interactive atlas, which UNM has been spearheading, especially Dr. Smith and Dr. Phillips. From our faculty. And this atlas includes a skin of color of every Fitzpatrick tone. And if you want to be a contributor, here is the email for that. And we also have a small grant for underrepresented in medicine medical students that want to rotate our facility. And the stipend is $1,500. This is for 2 medical students a year, and basically we want to include these medical students that may have a more difficult time to rotate in dermatology. And then briefly on diversity, this has already been touched, but basically, why is important diversity in the workforce of dermatology? Well, it's going to create a more robust educational experience because people are going to come from different backgrounds. They're going to have different ideas and different ways of seeing life. This has already been discussed. It improves the patient-provider relationship because patients can relate to their provider. It tends to be more approachable and inclusive. And it's important that there's more representation of the population at large. These minority providers tend to serve underserved communities and to stay in their community, and it creates a sense of social justice and equality. I just wanted to share this last slide. This is published this year in the dermatologic clinics. And I just wanted to show you that even though we're in 2003, 4.5% of the providers are Hispanic and 18% of the population is Hispanic. So there is no correlation on that. But the things are more dire for Native Americans. Only 0.1% of the providers in dermatology are Native Americans, compared to their presence in the community at large of 1 to 3%. Things are even worse if we go to subspecialties. I show you here for the different ethnicities. Perils, New Mexico, it's an underserved state. We are hiring, we need more dermatologists. Our patients drive long distance to see us, so it's important to address as many concerns that they have. Even if they don't have a concern for their acne, it's something important for us to address. And then telehealth might be helpful in some of the cases. Particularly, we do this a lot for follow-ups. As dermatologists, we should create partnerships with different specialties, including primary care. We should recognize that still we need to do more to be truly competent culturally. And there's several programs that UNM there we have done to reach out to the community, but always is more needed. And diversity, the workforce is really important because it should represent the society that we serve. I wanted to give a special thanks to my mentors at UNM, as well as to Centro Dermatológico Pascua in Mexico City. And I also wanted to give the heads up for the upcoming Skin of Color book chapter that in Hispanics that it's coming. This was written with Dr. Rodriguez Vázquez and Barbosa. I also wanted to give a special thanks to Dr. Carlos Linares from the UNM 3 Center. He's involved in research in Native Americans and Hispanics. He's my husband. And I wanted to give a special thanks to my patients for all their teaching and wisdom. Thank you so much. This is my email, and I'm open to any questions.
Thank you so much. Go right ahead.
We have a question in the chat. How did coming from a Hispanic background inspire you to choose a career in dermatology?
So I did my medical school in Ecuador. It's kind of different than here because you don't have the college phase. So early, I was already 20 years old when I decided that I wanted to do dermatology. All my family are physicians. They're in cardiology and internal medicine, but I truly was not attracted to any of those specialties. So one of my early mentors in medical school was a dermatologist, and I rotated with her one day, and that was it. I fell in love with it. I liked the very visual attraction. I like it that it's very visually and that you can diagnose a lot of things like that. And I also like that you have the ability to be not only a clinician, but also a surgeon. I like procedural kind of things. So for me, that was like a perfect combination. And the population, it's also amazing because you can treat patients since they're babies until they're 100 years old. So it's, I think all that attracted me to dermatology.
Awesome. Thank you so much. Are there any other last minute questions?
I think there was a comment that said from Dr. Clarence Wiley. Do you see that one? I'll read it.
Yes.
I've worked at a First American clinic for about 5 years now. I definitely concur on the high prevalence of HS and the more severe acne conglobata and dissecting cellulitis. However, I also see a lot of rosacea, about 70 to 80%, my best approximation. The rosacea, severe acne and HS often occur together with or without the dissecting cellulitis.
Yes, I will agree with this. Sometimes we have had also something very, just to add to that comment that it's absolutely true. Sometimes we have also have a phenomenon that I think we observe a lot in Native American and also in the Hispanic population, is that sometimes it starts like acne and then evolves to rosacea, and then it's difficult to see where one starts and one ends because sometimes they have both conditions in the same patient. Another thing is that we have this a lot, especially in Hispanic groups, this residual papules on the nose after acne has been treated. I don't know if any of you have observed that. But there's more like this incidence of having this fibrous papules in the nose of acne patients that are treated as teenagers being Hispanic. And I think that has already been published as well.
And then we have another question asking for recommendations or books or resources on Hispanic or Native American dermatology that you would recommend for further reading. I know you said one is about to come out, but
let me hold on a second. I wanted to share, let me share my screen again. So just wanted to point out, so these are some of the other references that I use. There's not a lot. There's not a lot out there. There's a lack, actually, mostly for Native American dermatology. There's a lack of this. There's a book chapters in this Taylor and Kelly's dermatology. I'm collaborating in the Hispanic one, but there's a Native American one that I had the opportunity of reading, which was very good. And then there's another book that it's edited by Dr. Burdell from Mississippi. And they have a great Native American chapter in his book. So if anyone wants to take a screenshot, these are some of the other references that I use, but there's not a lot for Native Americans, so it's very difficult to find.
All right, thank you so much. We are just so happy that you've been able to come and talk with us about this unique group of ethnic population that is just so in need of dermatologic care and being approaching with cultural humility, but also the amount of respect and understanding of some of those diseases that can be so severe, and how you can approach them in your way. So thank you so much. We appreciate you, and hopefully you'll be able to stay on with us in and out. But we thank you so much.